get started here. Thank you for joining the second in our three-part series on breaking down the quality payment program. We're really excited to have you on. Today we're going to be focusing on the HealthIT needs to support advanced payment models. As a note, this webinar is being recorded, and we'll be posting it to our YouTube channel. For those of you who aren't familiar with Audacious Inquiry, we are a health information technology and policy company. We do a lot of work in the private and public sector side. We work with a number of health information exchange organizations across the country. We do a lot of work with the Office of the National Coordinator and a number of other private organizations. So as I mentioned, this is the second in our three-part series. The recording of our first webinar is posted at this link, and the slides are actually available for download. Right now you'll see it in the kind of menu bar under handouts. So you can download the slides from today's webinar, get this link, and go back and watch the MIPS at a Glance webinar if you weren't able to join us for that. The third part of our series is coming up this Thursday. We're going to be covering how health information organizations can support MACRA, and we've also added content to that webinar on the implications of the 21st Century Cures bill that recently passed Congress, and the President is likely to sign today. So we think there's going to be a lot of great content in there to help HIOs think about how they can support MACRA and the various implications of the 21st Century Cures bill. So as I mentioned, I'm Kory Mertz. I'm moderating the webinar today. Genevieve Morris, the Senior Director and the leader of our HealthIT policy team here at AI, will be talking through the content. Genevieve has done a ton of work over the years on the Meaningful Use program, has helped a number of clients on that, and helped a lot of clients with audits. So she really knows the nitty-gritty of the program. Also done a lot of work with HIO organizations across the country and with ONC and others, really working on the details of these programs, and has that detailed experience. So with that, I will turn it over to Genevieve.
Thanks, Kory. So our agenda for today, we're going to give you a little bit of an overview of the Advanced APM content from the MACRA regulation, or sorry, from the QPP regulation itself. And then we're going to talk a little bit about the HealthIT framework to support APMs, and we'll make sure to leave some time at the end for questions. If you do have questions throughout, feel free to use the chat feature to send those over to us. When we get to the Q&A time, we'll try and get to all of the questions, or as many as we possibly can. So the Alternative Payment Models Incentive Program, which is track 2 of the Quality Payment Program. Where this gets a little bit confusing for folks is there are alternative payment models, and then there are advanced alternative payment models, or advanced APMs. For the QPP program, CMS used the term advanced APMs to call out a specific set of APMs that qualify to be in the program. And in order to do that, they set a couple different criteria. Most of these criteria come over from the legislation, so there really wasn't a ton of wiggle room for CMS around this. But basically, just because you're in an APM does not mean that you are in an advanced APM. And for some reason, my laptop just decided to go off. There we go. Just because you're in an alternative payment model, like a bundled payment model or a medical home, it does not mean this counts as an advanced APM. Only a certain set do. So for the advanced APMs, the APM itself has to require that 50% of its participants use certified EHR technology. And when we use that term CERT, we're talking about the CMS definition of CERT, which is a very specific definition of the HealthIT components you have to have. You don't have to have it in one product, but you have to at least have multiple products that make up all of the criteria. And you have to, as a requirement in the APM, have 50% of your participants using. You don't have to verify that they're using. There really aren't a lot of requirements around it, but it does have to be built into the contract. The second, the APM must provide for payment based on quality measures. So you can't just have an APM where you're not reporting any quality measures. That's a very important component to CMS, that you're measuring your quality against measures that are very comparable to MIPS, so that they can, obviously, from a national perspective, do quality measurement analysis. And the third is that you have to take on downside risk. So this is where a lot of APMs become not advanced APMs and are just regular APMs, because there are a number of APMs out in the marketplace where there is no downside risk, there's just shared savings. If you are in an APM that is shared savings only, bad luck for you, does not count as an advanced APM, and we'll talk a little bit about which ones do count as advanced APMs for 2017. The second item to keep in mind is that up until 2019, the only APMs that qualify as advanced APMs are ones that are run by CMS. So in other words, if you're contracted with Blue Cross Blue Shield or United Health or Aetna to do an APM, that's not going to qualify as an advanced APM. Even once we get to 2019, those APMs can add to your eligibility, but you still have to have a contract with CMS first. If you aren't contracted with CMS in any way for your APM, it's not going to count as an advanced APM ever. And unfortunately, Medicare Advantage does not count as being contracted with CMS. And then annually, CMS will publicly post and update the list, which I think we're going to get to in a second. We'll talk through that and as well as mention some of the plans CMS has indicated for adding models in the future. Some key terms, so you have your advanced APM, and this is an APM type. So it's a shared savings track 2 or 3, a next-gen ACO, the CPC Plus model. This is basically the model of an APM. And then you have the advanced APM entity, who is the actual organization who's contracted with CMS. And so this is going to be, if you think about a shared savings track 2 or 3, it's the ACO itself, the main organization who has that contract with CMS. And then you get down to the qualifying APM participant, or QP, and that's the individual eligible clinician who's participating in the advanced APM entity. So it's important to kind of understand these terms because it impacts if you can participate in the program or not and whether you have to do MIPS. So for 2017, the following are the advanced APMs that CMS has indicated will count and get folks out of MIPS, assuming they meet some other criteria. The comprehensive ESRD care, only the 2-sided risk model. They do have a 1-sided risk model that does not count as an advanced APM. CPC Plus, both track 1 and 2 count. The next-gen ACOs, shared savings track 2 and 3, and the oncology care model, 2-sided risk only. Shared savings track 1 is upside only, so they only have shared savings, no downside risk. So for right now, for 2017, CMS has said that track 1 does not count. They have, however, indicated that they are planning a track 1.5 or 1 plus, whatever they end up calling it. That's sort of halfway between track 1 and track 2 and 3. So in other words, instead of jumping all the way from no downside risk to full downside risk in a 2 or 3 track, they're going to give sort of a medium option where you're taking on some downside risk, but not as much as you would in track 2 or 3. In order to do that, they actually have to create a new shared savings track because it doesn't exist yet. And so that's something that they've indicated they'll be working on over the next year. And then there's a couple other models, particularly in the bundled payment world, where they're looking at adding additional models once we get to 2018. So qualifying APM participant, or QP. So the bad news is just because you're in an advanced APM, so just because you're in CPC Plus or you're in a track 2 shared savings ACO, it does not mean that you as a QP actually qualify to be exempt from MIPS. It doesn't mean that you qualify as a QP, in fact. What CMS wants to ensure is that they don't have folks going into advanced APMs and only having a handful of patients or a handful of their payment based out of that advanced APM. And so they decided to set rules around qualifying as a qualifying APM participant that has to do with how many patients you see or the percentage of payments that you get that are in the advanced APM. So the advanced APM entity, so everything all of the ECs are doing in the advanced APM entity has to add up to at least 25% of payments or 20% of the patient population who could be in the advanced APM have to be in the advanced APM. So let me say that hopefully a little bit clearer. If you have a patient panel of 100 patients and all 100 of them could be in the advanced APM, so they're all Medicare patients, they're all the right age, they have the right conditions, but you only have 10 of those 100 patients in your advanced APM, you're not going to necessarily qualify as a qualifying APM participant unless you maybe happen to spend 25% of your payments on those patients. So they just want to make sure that really eligible clinicians and APMs are really expanding the amount of their patient panel that's in the advanced APM. Those numbers do change year over year. So for 2017, it's 25% of your payments and 20% of your patients who could be in the APM. Those numbers do go up every year. It's not quite clear how much they'll end up going up because this is a final rule with comments, so CMS could change those percentages based on feedback that they get. If you end up being a qualified participant, you get to be excluded from MIPS, which is great. because basically all of your reporting goes through the Advanced APM entity. One sort of exception to that is that if you're in a shared savings track ACO, they do actually have separate requirements around the advancing care information / meaningful use reporting. And so if you're in one of those models, you actually might still have to report ACI measures in particular, but that's sort of the exception rather than the rule. In addition to being excluded from MIPS, you get a 5% lump sum bonus from 2019 to 2024, so you basically just get extra money on top of what you're already doing. And then in 2026, you get a higher update under the physician fee schedule. So that's all that you get from being a QP, but every single year you have to qualify again to be a qualified participant. And what CMS will do is every 3 months roughly, they will evaluate the percent of your payments or the percent of your patients that are in the Advanced APM, and they'll make a determination on whether you're a qualifying participant. Because they're doing that 3 times a year, it actually gives more eligible clinicians the opportunity to be a QP, which is a good thing. And once CMS has determined your status, they're not going to change it to a negative. So if you qualify in the first quarter, they're not going to take it away if it suddenly falls below the percentage, but you can get it if you fail at the first quarter. You can get it the second or the third. By August, everyone who can be a QP will know that they are a QP. So by August of 2017, CMS has guaranteed that you will know whether you are a qualifying participant. And if you fail to be one, then you are over on the MIPS side of things. APM performance and payment timeline. So again, this can be a little bit confusing. If you're familiar with CMS incentive programs, things always get delayed by a certain amount of time so that they have time to update their systems. So 2017 is the first QP performance year. 2018 is when you can get your first incentive payment, and then 2019 is your first payment year. And so it kind of spans out through 2020, and then keep in mind, starting in 2019, for payment year 2021, you have the all-payer Advanced APM option, which is the next one, the other payer Advanced APMs. So generally, if you're going to be in an other payer Advanced APM, what they'll let you do is basically add together your patient volume and your payment amounts from both the other APMs that you're in and your CMS Advanced APMs to get to a threshold, which should mean that more people become QPs. But generally, those other payer Advanced APMs have to meet the same criteria. So they have to have downside risk. They have to have requirements around using certified EHR technology. And so all of that sort of stays intact even when you go to these other payer Advanced APMs. So if you're looking at working with different payers to implement APMs, it's going to be important that you build some of that into your contracts with them so that they can qualify as you get into 2019. And Medicare Advantage, Medicaid, and commercial APMs all fall into this category. So if you have practices who are participating in the Medicaid medical homes in their state, that actually helps count towards the other payer Advanced APMs once we get to 2019. So stepping away from sort of what's in the regulation, we want to sort of give an overview, and some of you who were on our webinar months ago when the rule came out might remember some of this content. We created a HealthIT framework to support APMs. I will say we developed this under contract to ONC, and hopefully the report actually might be out in another week or two around this whole topic. But we interviewed a number of different APMs, so including ACOs, bundle payments, medical homes. We talked with HealthIT vendors, we talked with payers, and basically what we did was try to understand what are folks using right now to meet their HealthIT needs in APMs, and what do they need as their patient panel expands to include more and more patients under an APM. And I will tell you the secret is they need higher levels of automation. So what we did is we took the HCP-LAN, so the Healthcare Payment Learning and Action Network, which is a public-private collaborative. They created this HealthIT framework to lay out the different payment models. So on the left, you have your pure fee-for-service, that's your Category 1. Category 2 are your fee-for-service that have things like pay for performance built in, reporting of quality measures, and basing some of your payment off of that quality aspect, but still at its base, still a fee-for-service. And then category 3 are your APMs that are built on fee-for-service architecture. And so that's sort of a number of the ACOs, like your track 1 ACOs, are all really built off of the fee-for-service architecture. And then you have category 4, which is your population-based payment. And a really good example of that is here in Maryland, we have what's called the all-payer rate setting system, where all of our hospitals get one bundle of money for the year. And they basically split it amongst them and have to manage the population health as a whole and as a group. And so as you move from left to right, you get more into the value-based payment models and more into the APMs. And as we were talking to folks and sort of understanding where they fell on the spectrum, it made a lot of sense for us to sort of layer the HealthIT needs over this concept of moving from fee-for-service all the way over to a population-based payment model. And what we came up with was this HealthIT framework, which we're going to delve into. I know it's a little bit small on the screen, but the top part is really what the current HealthIT capabilities are. So this is what folks are doing right now, whether they be in the fee-for-service model in category 2 or whether they're already doing some of the population-based payment models. These are the HealthIT capabilities that they're currently using to support. And I will tell you that a lot of these processes are very, very manual, even when they're using technology to support them. That was one of our really big findings in this work is that they're doing a lot using people and using manual work in things like spreadsheets, which is not ideal if you have 80% of your population in an APM. You really just can't staff that at some point, particularly in smaller provider practices. The bottom is from right now where we think our ideal HealthIT capabilities are going. Now, obviously, technological changes could modify this, but this was sort of our best guess with what's currently in the industry, where standards currently are around interoperability with where we think we need to go. And what we want to do is just focus a little bit on that ideal state of where we want to get to. So the first item there is clinical data capture at the point of care. So obviously, wherever a patient is receiving care, you have to capture their clinical data. In category 3, that's really still focusing on provider practices and health systems. But as you move into the population-based health categories, you really have to expand into community-based programs where patients are receiving other services. Because if you fail to do that, you really can't prevent readmissions. If you think about a lot of the populations that are at risk, homeless or folks living in shelters, or folks who maybe can't afford to buy groceries or have chronic diseases who get managed at, the local YMCA, right? All of that is data that's not currently in our clinical health system that really needs to be added to our clinical health information in order to provide more rounded view of the patient and ensure that they're really getting all of the services that they need in order to prevent them from going to the hospital. And so as you move from left to right, you really have to start getting an interoperable EHR that has all the clinical data moving around and then starts to incorporate some of that less traditional clinical data from outside of the current healthcare continuum. Care coordination and management, not surprising that this is a very large category of capabilities. Care coordination is sort of the bedrock of almost every APM, with the idea being that if you are better managing the care of your patients or your population, then you're preventing them from using services that perhaps they don't really need or could receive in a lower cost setting of care. And so things like a closed referral loop, which right now we aren't even close to having, unfortunately, because the technology and standards just aren't there yet. But knowing that your patient went to that specialist and giving the data back is really important. Having a shared care plan that the patients and their caregivers can have access to. And again, as you move towards that population health, that those community-based services can have access to and update in real time. Event notifications that are integrated into your workflow, whether that be from a hospital visit or a smarter alert that where you're using patient-generated health data to know, oh, my patient's blood pressure is spiking. Maybe we need to call them and get them to come in. Near real-time benefit and eligibility information, which is really important for managing referrals. A provider value score, again, really important for managing referrals, knowing that when you're referring your patient over to another provider, that they provide both efficient and effective and high quality care is really important to managing the care of that patient. And then event care gap change and risk score, patient-generated health database notifications, really just beefing up where we currently are with our notifications, which primarily are hospital discharge or hospital admit alerts. Risk scoring. So as you move across, risk score becoming really important. A lot of payers already do risk scoring, but alternative payment models, particularly ACOs, really need to be able to risk score and stratify their patients so that they can manage a population and reduce the cost of a particular population. So as you look in category 3, there's a need for real-time risk scores that are based on claims and clinical data. And then as you move into the population health, you need real-time risk scores that are disease-specific. So if you are doing a bundled payment model that's specific to diabetes, for example, having risk scores that are specific to diabetes care is very important for managing that particular population. And then again, as you get into that 4th category, incorporating socioeconomic data into your risk scoring so that you know whether your patients maybe can't afford their medication or they can't afford their next meal becomes really important for helping to manage the care of that patient. Data aggregation and attribution, this should be super surprising to anyone that we really need to be able to pull together clinical and claims data. Right now, a lot of that is very siloed. Very few organizations have the ability to do this for a lot of different reasons. Some is standards-based, some is a lack of willingness on the part of payers to provide some of this data. But really, there's a need to aggregate that data together so that you can do things like risk scoring and quality measurement and care coordination. And to do some of that, you need an interoperable provider directory, which we'll talk about a lot more actually in our next webinar because of some of the Cures Act language around provider directory. And then you really need to get to close to 100% accurate linking of your data. So in other words, if you're not linking together your patients accurately, you're not going to be able to have accurate risk scores because you're going to be missing data points. And so you really need to get to close to 100% if you can. And then quality measurement. So in category 3 there, it's real-time patient-centric ECQMs that are calculated across a system or contract. So being able to pull together all of the data from every participant in your APM to calculate a real-time risk score is important. And then as you go to category 4, it's across a set population. Really, really important because providers need real-time feedback on how they're doing with quality measurement in order to improve. Giving it to them once a year or once a quarter really doesn't get them to where they need to be able to make improvements, and frankly, that's sort of the world that we're living in right now. And then the last piece is financial management. So if you are going to try and manage an ACO or a bundled payment, you really have to be able to calculate your total cost of care, and that really comes from more than just clinical data. It has to be claims data and clinical data, but really importantly, it also has to be services data. So if you're in an APM that is providing things like transportation services to your patients so they can get to their visit, or you're providing someone who can go out to their house and help them understand their medication each day or take their blood pressure every day, that's service data that we're really not incorporating today into the total cost of care. But in order to manage these APMs long-term and ensure that we're actually saving money and providing more efficient care, you have to really incorporate that services data. And that also means incorporating the cost of your HealthIT. Everything that we just covered is not a low cost. If you actually set up all of this HealthIT, it has a price tag to it. And so incorporating that into your total cost of care becomes important for year over year managing how much things actually cost, which again is really where we want to get to with these APMs. The idea is to provide high quality, efficient / low cost care. And we firmly believe HealthIT can be an underpinning to that, but we obviously have a long way to go from our current state to where we need to get to. And with that, I think we are on to questions. So.
Great, thank you, Genevieve. If you have any questions, please put them in the chat or the questions panel, and we'll tee them up for Genevieve. So the first question we have, Genevieve, can you give a sense of what the expectations are as far as the number of providers who are going to be participating in the Advanced APM side versus the MIPS track for 2017 in particular?
If there's an excellent question, I will not remember the percentage off the top of my head, but it is a very small percentage who will be in a qualifying Advanced APM. Or who will be in Advanced APM and actually meet the thresholds they need to be a QP. So the majority, I think it's somewhere around 70% roughly, will be on the MIPS side for 2017, with the rest falling into the Advanced APM side or some amalgamation. If you're in an APM that is an Advanced APM but you're not a QP because you didn't get the percentage, you have the option to do what's called MIPS APM reporting, which is sort of a hybrid between the two programs. And so I think CMS anticipates that a number of APMs will end up in that track. So all the Track 1 ACOs are eligible to do the MIPS APM reporting. But for right now, it's a very low percentage until folks start moving out of Track 1 ACOs.
Great. So then the next question, you know, as you think about the certification, the technology requirements that CMS has put in place for advanced APMs, how does that compare or contrast with what providers are required to have for the MIPS track?
It's a good question. So CMS actually tried very hard to align this together. So when you look at the advanced APM requirements, the definition of cert is the same for both MIPS and the advanced APM. So that's the same. Once you get past that, though, each advanced APM has slightly different health IT requirements. So for example, the CPC Plus program requires that providers participating in the program use technology that is certified to the clinical quality measure criteria, which are C1, C2, C3, and C4. Not that anyone cares about those. But they specifically have to have technology certified to what is actually an optional criteria, which is C4, and that's the ability to filter your CQMs at the practice level. The other advanced APMs, like the shared savings track, don't have that requirement that you have to use certified technology to calculate your CQMs. You can use a lot of different methods to calculate your CQMs in a shared savings track or next-gen ACO. And so while they tried their best to align sort of the baseline requirements, how you actually use the certified health IT varies across programs. And so folks who are in those advanced APMs really need to understand what their individual requirements are.
And has CMS signaled anything about their future intentions around the cert requirements for MIPS and the advanced APM side of the program?
At this point, they haven't really signaled anything in the regulation. I think my guess would be that as we get more experience in the advanced APMs using certified technology, they may start to change requirements. The CPC Plus is one of the only advanced APMs at the moment that has those additional certified health IT requirements. And so I would suspect that once CMS tests that out with CPC Plus, if it goes really well, then they might roll that out to some of the other advanced APMs.
Great. Looks like that is our last question, and we are at the end of the time for the webinar.
Great.
So we appreciate everyone's attendance today. Here's our contact information. If you have any questions, we'd certainly be happy to have additional conversations with you. And again, we'd encourage you to join us on Thursday at the same time for the third part of our webinar series, where again, we'll be digging into how health information organizations can support provider success in the QPP program, and also talk through the implications of the 21st Century Cures Bill. So with that, thank you all for your attendance today, and we hope to have you join us on Thursday. Thank you.